Good evening, everybody. We are gathering again, and it's wonderful. I know we have a lot of people logged in. I'm lucky enough to be the moderator for this fantastic panel of experts, people who've had a lot of experience on the front line of taking care of COVID-19. Okay, so everybody can see it?
Yeah.
Okay, so welcome again to COVID-19 management of patients with mild, moderate, and severe cases. Everybody should be logged in. We are going to move forward. So I'm honored to be the moderator tonight. I work at the University of Chicago. I'm the director of bronchoscopy and the co-director of our lung cancer screening program, and currently covering the intensive care unit, the non-COVID unit at the moment. I have my panel, who everybody should be able to see, starting with Dr. Jerry Kreiner, who's the chair and professor of thoracic medicine and surgery at the Lewis Katz School of Medicine at Temple University. He's also the director of the Temple Lung Center and Pulmonary and Critical Care. So, Jerry, thanks so much for being here tonight.
Thanks, Cal.
We've also got Dr. Neil Patel from the Mayo Clinic Jacksonville as a critical care specialist, internist, and pulmonologist with a focus on COPD and lung cancer. And Dr. Patel, thanks so much for spending time with us. He's on mute. Professor Lee is the chief physician and doctoral supervisor and the deputy director of the Guangzhou Institute of Respiratory Health and the first affiliated hospital of Guangzhou Medical University. He's also the vice president of the China Thoracic Society. So, Professor Lee, thank you so much for being here.
Hi, hello everyone.
It's great to have you. Professor Wang, the chief physician and doctoral supervisor, director of the Department of Respiratory and Critical Care Medicine, Peking University First Hospital. He's a Chinese council member of American College of Chest Physicians, member of the World Association for Bronchology and Interventional Pulmonary, and head of the Interventional Respiratory Medicine Group of the Chinese Thoracic Society. Professor Wang, thank you so much.
Good morning.
This is how busy the man is. He did a quick bronchoscopy actually before joining our conference. He logged in this morning, dashed off, came right back. He's impressive. Professor Lau, professor of chief physician, doctoral supervisor, and professor, of course, at the West China Hospital, Sichuan University, deputy director and Department of Respiratory and Critical Care Medicine, member of the standing committee of the Special Committee of Respiratory Endoscopy of the Chinese Medical Association. Thank you so much for being here tonight.
Thank you. Hi.
Good morning for you.
Good morning, yeah.
Professor Tom is the honorary clinical assistant professor at the University of Hong Kong and is associate consultant at Queen Mary Hospital. Professor Tom, thank you for being here.
Thank you, Carl.
And that was it for my intro. So we're going to start, as everyone has the agendas in front of them. We are going to begin with Dr. Kreiner. So I'm going to have you, Jerry, take over the sharing the screen part and let you roll.
I think you have to
pause. There, I paused it.
Good. Thanks, Kyle.
Absolutely.
It's a pleasure.
Hey.
It's a pleasure to be here tonight with my colleagues. So I'm going to give a brief overview of the status of the United States in terms of COVID-19 infection, and just give a brief overview of an experience of a U.S. center who was thrust in the midst of this, and what our experience has been and what we've done trying to combat this this serious infection, which is devastating many people. So overall, this is the outline of the worldwide cases of COVID-19 as of this morning. And as you can see, in the northern hemisphere, across the globe, countries have been affected, from the first cases that have been described in China and throughout Southeast Asia, to the heavy penetrance that has occurred in Western Europe, and then finally, most recently, in the United States, with a marked surge and an increase in a number of infected patients and those who are critically ill. This is one way to look at it, but I think a more relevant way to look at it is when you look at it like this. The number of per capita cases across the globe where COVID-19 has affected patients and has resulted in death. This looks at patients that in the orange who've had more than 200 cases per 100,000 people versus those in orange, which is 100 cases per 1,000 patients or 100 deaths per 100,000. And then where there's less cases, 10 per 100,000 overall. And one can see the United States and other parts of Western Europe have about 100 patients that have died per 100,000 cases. But in some places in Western Europe, such as Italy and Spain, this has been devastating, that twice the mortality has been seen in those countries. So this is a disease, it's not influenza like Dr. Wong and I had talked about earlier. This is a very serious infection that can result in death, not only in the elderly, but in those who are of younger age. These are the projections for COVID-19 in the United States if we currently maintain social distancing to the degree that we have invoked right now. This looks at projections in the number of cases where total resources would be needed in terms of hospital beds, ICU beds, and the needs of invasive ventilation. This is going to peak in the United States in about 3 days from now on April the 11th, with the number of cases in average across the United States where maximum healthcare resources will be needed from a respiratory standpoint. The peak of death will occur later, unfortunately. That's because the sicker patients who are ill will be taken care of in the ICU and will succumb later on in their illness. So the cases of infection will follow first and peak, and that will be followed by the number of hospitalizations and a number of patients that unfortunately die. And this shows the peak of death in the United States. If we maintain the social distancing that we now are doing through August the 1st, that fortunately we'll see only 60,000 deaths, something that in the United States was unheard of in the past. We thought that it would not be this type of impact, but this is much better than the earlier projections only a week ago, where it's thought up to 200,000 Americans would die if COVID-19 wasn't seriously addressed with social distancing. This looks at the number of cases reaching plateau in the United States. And you can start to see, if you look at an average across the United States, that at April the 7th, we are starting to reach an asymptote of the plateau overall. We haven't reached the plateau yet, but it looks as though the curve is starting to bend. However, the curve is only relevant where you live. In a large country like the United States, there's different case rates that you can see that occur, showing the same number of cases per 100,000 like I showed before, in the same color coding. The darker orange is where there's a doubling rate that's every 3 days, as opposed where it's like orange or yellow, where it's 5 or 7 days overall. So if we look at the New York and New Jersey region, we can see that they've increased the peak doubling rates and they're starting to slow down. But if we look at other states in the United States, such as Michigan in this area, or in Louisiana, which is down here, or in Pennsylvania where I reside, we are still hitting our peak rates of doubling every 3 or 7 days. So this only depends on where you will hit peak, is where you live in the United States. And in other large countries like this, you can look at the national average, but it's only going to be relevant to you for your healthcare resources and for your management of your patients where you live. So this is where I live in Philadelphia, the tri-state region. And as you can see, Philadelphia is the gray here. We are still on the sharp rise of the curve, and the number of cases that are increasing in our tri-state area. We expect to hit peak this weekend, and after that, we will hit peak resources for the number of hospital beds we need, the number of ICU ventilators, and then our death rate will increase following that about 5 or 6 days later. So it depends on where you are and where your case rate is to manage your resources to take care of these patients. So let's look for a second at the fatality rate of COVID-19 across the world and in the United States. And as you can see, the curve has started to bend in Italy and Spain. But in the United States right now, although the case rate, the number of infected people might start to be hitting the plateau, and the hospitalizations in New York City have started to hit the plateau today, the death rate has not hit the plateau in the United States. And again, when we look by the variation by state, in a large country like the United States, New York still hasn't hit plateau, but New Jersey, Michigan, Louisiana, and Pennsylvania are still on the sharp parts of these curves and will not reach the plateau in deaths for a period of time, maybe 1 to 2 weeks. So it was said in the beginning, especially in the United States, when we had the cases that broke out in a nursing home in Seattle, Washington area, that this really was a disease that affected the infirm, those who were in a nursing age home, those who were older, those who had comorbid conditions. But as this disease became more prevalent, we recognize the same thing that our colleagues in Asia and Europe have seen, that even young people, 50s, 40s, I have 3 people that are 19, 20, 21 now in the hospital who are younger can get devastating consequences from the disease. This is a patient that was a 45-year-old that was seen in outside medical center in emergency room a week ago, had minor symptoms, cough, shortness of breath, mild fever, sent home, and he presented to us a week later in ARDS and had to be intubated and proned, and fortunately lived but stayed in the hospital for about 3 weeks. The other problem that compounds this is making an effective diagnosis and making the right diagnosis and making it quickly. Using the nasal pharyngeal swabs for nuclear antigen extraction is problematic. This is a patient to the right whose nasal pharyngeal swab was positive and her HRCT is positive for COVID-19 disease. But this is another patient that has similar clinical presentation and similar exposure risk who has an HRCT that's compatible or classic for COVID-19, but the nasal pharyngeal swab is negative. So how do you treat this patient? Can you treat them the same? Can you send them home? Can you remove them from respiratory isolation? And we feel that that would be unwise. And this is the problem that we see in our institution. We currently have treated 624 patients in the last 3 weeks with COVID-19 disease. In the blue here is showing the people that are positive for COVID-19 by nasopharyngeal swab, nuclear antigen extraction. But these in the green are patients that have similar profiles on HRCT and clinical severity of disease, and their nuclear antigen extraction by nasopharyngeal swab are negative, but their CT is positive. So these people should be treated the same. This is a major problem right now that needs to be addressed with precise diagnosis and immediate turnaround at diagnosis within 5 to 15 minutes. How sick are these patients? From our description of taking care of over 600 patients, well, this is our first 110 that are classified by severity stages as shown here: mild, moderate, severe, and very severe, by these clinical, radiographic, and these cardio respiratory sort of parameters. And as you can see, approximately 80% of these patients have either very severe disease or severe disease on presentation and require high-end respiratory care and critical care to maintain their survival. So what are the lessons that we've learned in our it was 578 this morning, but now it's 624 this evening. That's how quick this is overall. You listen to your colleagues in China, Italy, Spain, and New York City on how to prepare yourself for the influx of patients who are sick with a high respiratory demand. And you need to prepare yourself by having policies and procedures in place to diagnose, treat, and prevent the spread in the patient population you serve, but also throughout your facility and the staff who are treating these patients. COVID-19 becomes a primary concern for any medical center in a cluster zone. You need to have more than general hospital and ICU beds. You need, in my opinion, have a separate facility to take care of these patients, or segregate off an appropriate size of your facility to be able to take care of these patients, both the general concerns as well as the ICU needs. Respiratory equipment is paramount: intubation, positive pressure ventilation, high flow nasal therapy, BiPAP, and other forms of elite respiratory support. Protective gear is paramount for your staff to keep them healthy so they can care for the patients. And you need to organize multidisciplinary teams of providers. People that you usually use, such as hospitalists, anesthesia, pulmonary critical care, radiology, infectious disease, etc., but cardiology, rheumatology. We even have neurosurgeons that round on us as part of the multidisciplinary team that complement the 30 teams that we have taking care of COVID-19 patients. And finally, you need high throughput testing and turnaround for COVID-19 care, and implementing a research structure to support the diagnostic and therapeutic options and explore them for this high demand of very sick patients. So that's been our experience so far. And I have to say, I thank my colleagues in China, Dr. Jinglong Chen in Wuhan, who helped me immensely with preparing us, and other people on the panel, such as Drs. Li, Wang, Lou and Tam, who have given us great advice on how to take care of these patients. Thank you very much.
Thank you, Jerry. It's what are you expecting? I know the data is showing it. What are the realistic expectations for you to start to try to plateau? And have you had to run into scenarios of being worried about your number of respiratory equipment for that degree of patients?
Yeah, we've started to do triage of the ventilators in the sense that if we have patients that reach a level of stable ventilation, we take those higher-end ventilators and save those for people that might need more aggressive forms of ventilator support and use ventilators that have lower functional capabilities because those patients don't need them. So convert some BiPAP units or use Trilogy units for ventilation that we normally wouldn't use and save the higher end ventilators for patients that we need who are more acutely ill. We also have on reserve our operating room ventilators to be able to use, our travel ventilators that we use for rescue missions for our ambulance crews. And we've used our durable home equipment vendors to support us with home mechanical ventilators that aren't in use so we can have them on reserve. So far we're good. We have in reserve over 100 support ventilators if we need them to maintain the surge, which we think in Philadelphia will be over the next 10 days.
Great. We'll obviously save time for a lot of questions at the end. I want to make sure that we're moving forward onto our next presentation. Professor Terrence Tam, the China update. Jerry gave us the US update with a hyper focus on the experience at Temple. If you'll unshare your screen, Jerry, and pass the ball over to Terrence.
Yeah.
No, actually, Dr. Lee is giving the update.
Oh, my mistake. Okay, then someone gave me the wrong agenda. Professor Lee, fire away.
Yeah, okay.
Perfect. Okay.
Can I get rid of it?
I think you did. Now
Can you see my slide?
Yeah.
There.
Can you see my slide?
Not yet. Jerry, I think you have
Not
to do, there's a button where you have to hit to stop sharing.
Sharing.
Way at the top.
Way at the top. Stop sharing. Yes.
And then once you do that, then Professor Lee's able to take over and start sharing.
Yeah. Let me just get out of this for a minute. I'll leave and come back.
Okay.
In the meantime, I'll say just now what Dr. Kreiner said is very important. I think we have seen the in previous SEIR model, any model. Previously, we have not been addressing migration numbers, and Hong Kong have seen the impact of that. So we were holding our fort pretty well until our overseas students start coming back, and then we hit another peak. So yeah, that's important. So managing your own numbers, and then also looking at what about when other cities start commuting between cities, then you need to estimate that number as well. Yeah.
No, that is a good point you're making, especially for a lot of people that are working on computer models, either at national levels, but even at regional levels. Is the influx of is your population relatively mobile? Like you said, a lot of students returning from abroad to Hong Kong.
Yep.
As various classes have been canceled in the U.S., for example.
Yep.
That influx.
Yeah.
Well, I'm imagining that a phenomenon we're seeing in lots of places.
Yep.
I would like.
You saw Dr. Falls. Oh, sorry. Go ahead.
Cap. So can I present a slide? Oh, okay. Shreya is here. So.
Oh, okay. After his, then please you. Okay. Take it away.
Okay. Good evening to our American colleague, and good morning to Chinese colleague. And today I'm talking something about the epidemic situation in China. This is the data from the up to the 6th April. So you can see here the total confirmed patients right now in China is about 80,000 cases right now. and see the new confirmed cases is just several cases per day. This is the update information. As we know, the COVID-19 was outbreak in China about last December in Hubei province, in the most severe cities, Wuhan, and we can see here the mortality rate in Hubei province is about 4.7%, and in Wuhan city is about 5.1%. But outside of the Hubei province, the mortality rate is about 0.84%. And from the March 17th, the cumulative import case was accounted for more than half of the exist confirmed cases. Here we can see the input cases here in China. And another concern, main concern in China now is the asymptomatic patients. Here's the just the pre-printed paper sum up the 24 asymptomatic cases in Nanjing, China. About 20% of the cases develop symptoms during the hospitalization, and 40% of the cases have typical finding of the chest CT, and about 30% of the cases experience no symptom or signs of COVID-19 with the younger age. And next, I'd like to talk something about the measures for the controlling COVID-19 in China. I think the most important measures is the lockdown Wuhan on 23rd January 2020. It means don't go to Wuhan, don't leave Wuhan. And another measure is transparency for the announcement of the number of the diagnosis in each city nationwide. Also, the intervention mechanism I will talking about later. And wearing mask is required in public area, a public place. Here saw that Dr. Zhong announced on January 20th. He said that the definite human-to-human transmission, and also confirmed that medical staff have been infected. And after 2 days later, the January 23, Wuhan was locked down. So here, here we can see no one in the street. And here we can see after the lockdown, 23rd January, 2 weeks later, the numbers, the peak of the cases reached the peak of 2 weeks after the lockdown, and four weeks later, the cases go to the low level, which means it's under the basic control. For the another measure down to the community level, every entrance of the apartment, the people go in or outside and receive the body check, and only the protection, that means social distancing, and early detection, early diagnosis, and early isolation. This is the paper was published last week in Lancet. The Fanchang Shelter Hospital. It was invented or is by Dr. Wang Chen, one of our leading physicians in controlling COVID-19 in China. He invented a concept that the shelter hospital, a novel concept for the responding to the public health emergency. This is the picture of the hospital. And also masking in public. Here's this picture shows the Wuhan yesterday. The first day of the unseat in Wuhan, so it seems go to the normal, and it is the Wuhan. And outside the Wuhan, I think in China, most of the place in China is almost go to the normal working life or working or life. Okay, that's my talk. Thank you very much. Okay.
Professor Lee, thank you so much. That was fantastic. Having been to Wuhan before, to see pictures of empty streets in Wuhan is crazy to think of that, because it's usually so busy. Thank you. I know you have something else to be at. Did any members of the panel have any specific questions? I know Professor Lee at some point I think has another meeting to go to, or maybe some procedures. Do any members? Yes, Guangfa Wang.
Thanks, Shi. So give a very good introduction of Chinese experience. So I should emphasize that the control of COVID-19 should not be the task of medical service system. So it is a social system. So the government should be very, very responsible for the control of the disease. So economy is another consideration, very important consideration of the government. But if we are facing a pandemic of COVID-19, so economy is the second consideration, and the public health should be the first one. So I would like to share the slide. So, and perhaps Dr. Lee had showed this, but I think it is very important to have a social regulation for control of the disease. So here is the Chinese trend of the COVID-19. So different severities. So the cumulative number is increasing, but we have a shift. So the lockdown of Wuhan so change the trend of the curve. So that is very, very important for the control of the disease in China, as Wuhan have a lot of people go all of China. So if you do not close Wuhan, so the source of transmission is spread all of China. So lockdown of Wuhan is very, very important. So after several days of lockdown of Wuhan, so the curve changed the direction. So that is very important. So I strongly recommended that United government should pay more attention to the infectious disease, and should have more strict regulation to control the disease. That is my comment. So
No, thank you for sharing that. I think you're right. The challenge in I think many countries, and the U.S. has been facing this, has been a lack of a full representation of the severity of this at a government level, both national and then regional and even local. And we're seeing it. We're seeing it in different places where people are taking it more seriously. But as was already highlighted in the Hong Kong experience, migration, if you're coming from a place that's not taking social distancing seriously, and you move to another part of the country that is, you are potentially bringing it right in. And we're going to see another spike, just like Hong Kong appreciated. You know, the challenge is the ability to lock down. There become real challenges for that in the U.S.
Yeah, so I think China is right now. China is much better. So I think different country, different region has their own conditions, but I think to keep high alert to the disease is very, very important. So you can adopt a different regulation according the country or the region's condition. So so in China, Wuhan is very, very special, but other cities is very similar cities in United States. So we are right now we are facing imported cases. So, but in the past, different cities have community transmission of COVID-19. But at early stage of the epidemic, so all the cities adopt a very strict regulation to control the disease. So then we succeeded. So that is the key point of the control of the disease in the city. Thank you.
Thank you. Any other specific questions from the panel? Then obviously towards the end of this, we'll get towards, we'll have a lot of questions that have been submitted from participants. Any questions directly on the China experience? Okay, well then let's move on to our next part of our agenda. If it's still the same schedule I was handed earlier. Fengming, I think you're going to talk about diagnosis. Do you have slides?
Slide. I think, right?
Oh, you're on next? That's fine by me. Fire away, Karen. Call you.
Yeah, so I would post this. So
the way we're going to do this, whoever's
Dr.
next,
Lu can answer some more questions.
Whoever's next, you just tell me and we'll be fine.
I can answer some questions. Okay.
Yes. So I'll be the moderator for this. So these are the questions from the internet and from some of the doctors from previous sessions. So the first questions they have is that there are certain degree of false negative rate for the nasopharyngeal swabs. And they're interested to know whether this is just from the timing or is it from the methodology of the test, and whether this false negative is the highest in the first week or so. So open this to the panel. I myself have, at least, well, from what we know, is probably for the COVID, the load is probably the highest early on. So I don't think it's the timing. Testing itself probably, I would believe that has both, is a function of both the test itself and also how you take the swab in some sense. But I'll pass it on to the panel to see whether you have other views.
Okay, I have some opinion about this question. And first, I think it's the time for process the samples. we suggest that the samples should be tested within 4 hours. If longer time, for example, 24 hours, you should store the samples in 4 degrees. If you want to test it in later time, longer time, you should preserve the sample in lower temperature. It's the one factors for the samples. And also we have a study that we have 101 patients. We collect the sample with the nasal swab and at the same time pharyngeal swab, and we find that the nasal swab have had the almost 90% positive, but only 50% positive with the pharyngeal swabs. So I suggest that we should take the nasal swabs because you can just stand beside the patients and take the example. Not like the pharyngeal swab, you have to face-to-face to the patient. This is the other thing. As to the time, I think there's a paper, 2 papers. One is Nature, the other is New England Medicine Journal. They tell us that from the maybe within 6 days from the onset of the symptoms, you can test the virus load is very high in the swab and also sometimes in the store. So maybe the time is the other question for it. Okay, that's my answer for it.
For Hong Kong, we also, I have shared a little bit last time, we have started to do a lot of deep throat saliva. And we also found that if you don't put it, we don't send fresh and we don't put any viral transport medium, the yield is significantly lower. So either we need to store it or we need to put in some viral medium. And yes, I think some of the study have shown that the nasal, very early on, well, at least actually throughout the whole course of the disease, the nasal carriage is higher than the throat carriage. Any others? If no, then we move on.
Our own experience is that we do a test, and then obviously if negative, the person is considered still under investigation for another 48 hours because of this 25% false negative rate, especially within the first early stages of the disease.
Yeah,
I'm sure it's similar also, for Jerry.
Yeah, that is also this next question, which is whether they're asking whether they should repeat the test. Yeah. Yeah,
okay.
Dr. Wang?
My comment is that I'm sorry. So you move to the next question. Oh, okay.
No, it's okay. It's okay.
Okay. So it is frequently in Wuhan about the sensitivity of COVID-19 virus PCR. So it is said that only 30 to 50% of the patients have PCR positive. So some pulmonologists thought that is the technology itself. So, but to my opinion, so it is wrong. So PCR is still a standard diagnostic method for COVID-19. So the problem is why we have so low sensitivity of the test. I think the sampling technology is very, very important. Just you have mentioned the medium, the different sample. So at the very early stage of COVID-19, so at that time we don't have the name COVID-19. We use novel coronavirus pneumonia. So some patients have a negative PCR with nasal or pharyngeal swab. But when the patient accept intubation and get a lavage, so it is positive. All 7 patients accept the lavage have a positive result. So that is very important. So different sample can cause different sensitivity. So we in Beijing, so there is a study. So they compared the nasal pharyngeal swab with sputum. Sputum is better. So this is one issue for increasing the sensitivity of PCR. Another one is how do you get the sampling? As I know in Wuhan, so as the clinician, not clinician, so mainly nurses. So when they are in the isolated ward, they wear coverall suits, thick mask, and goggles. So they have very busy work, and so they and also some less trained with nasopharyngeal swab. So that is the reason why we have low sensitivity rate. So another alternative method is that we can collect multiple samples. We can collect a nasopharyngeal swab. We can collect a sputum, and also we can collect a stool. So we do multi-sample test. So then only one is positive. That is right. So this can increase the sensitivity. So that is my suggestion.
Yeah, thank you. And also we in Hong Kong, we recently in our microbiology lab, we also showed that another factor, I suppose, is also the primer that we use because it's a new disease early on. And it seems that with different primer, there are also changes in cross-sensitivity with other viruses, with the usual coronavirus. And some primer, if you use multi-primers, then the sensitivity and specificity also changes a little bit, I suppose. So I guess that covers a little bit of the second question as well. But the second question is, when should a test be repeated to improve the sensitivity if the clinical suspicion of COVID-19 remains high? Any view on the panel? My view, of course, is that this should always be repeat. I have some strong reservation on repeat going for a bronch. To be honest, I would repeat anything a little bit less invasive, but I open this to.
Do you wait a certain amount of time before repeating? 24 hours or?
24
do you
hours.
wait 24 hours or?
I think it's 24 hours is makes sense, I think.
Our hospital's policy has been 48, but that's also been from the perspective of wanting to make sure we preserve the ability to perform the test, which has been one of the other critical shortages within the United States, the inability to perform the test both in quantity and rapidly. That has been extremely limited rolling out through the US.
Kyle, do you guys have concerns about PPE in those 48 hours that you're waiting, or do you guys relax the contact precautions? We don't. They're still considered, their designation is person under investigation. So we have a COVID pathway, person under investigation pathway, and a fine pathway. You're fine.
So in China,
we have concerns of equipment.
So in China, we have a guideline so for handling these situations. So in China, if, for suspected cases, we will collect a swab or other samples for PCR. So if it is negative, we will get another one after 24 hours. So if it is still negative, the patient will be ruled out COVID-19. So after we have antibody test, so we added another criteria. So if the patient after the onset of the disease, so the antibody on the 7 days, after the 7 days, so the antibody is still negative, then COVID-19 should be ruled out. So that is what we done in China.
Okay, so I think that's pretty clear, and we've covered quite a bit in the first question. So I'm not sure why this is here in the diagnosis, but I think this has to do with our previous question on the pediatrics question. So initial data suggests that elderly tends to be more affected, but recently in the US, there have also been some pediatrics death, and their internet question on the changes in this, and wanted to see whether the panel has any view. I'm not sure whether we have the pediatrician here. Yeah.
We don't have the children in our hospital when I stay in Wuhan, but I think there's maybe no report about the death of the children in Wuhan. So I still wonder why there's children died in USA. I don't know why. Maybe this question is just about the maybe some mutation about the virus and another kind of things, but I don't think so. Maybe some just something wrong in the treatment or some other things. I don't know. I have no idea about this question. Yeah.
Okay.
So
why don't we move on?
Yeah. I think we need to move on a little bit. So there is, and to shift gear a little bit, there is a few questions a little bit on the epidemiology, more on isolation and infectivity. So a few questions that I think we can discuss together. So there are a few questions on this. I think we, Dr. Kreiner have covered a bit on the, it's pretty much on the SIR model, whether the US is reaching the peak. But I think this is a little bit more clinical, whether the asymptomatic carrier, how long they remain infective to the general population, and whether how long should they be quarantined. I think these two questions can be discussed together, and whether the panel has any view.
I'd like
go ahead
to give some comments. So we can talk about Chinese experience. So the last question is that what we do is that after the patient is discharging from the hospital, so the patient will remain quarantined for another 14 days. So it has been proved that it is safe. So right now there is no report for that discharged patient has some evidence of transmission to other people. So I think it is safe, but it is expensive. To my own opinion, if the patient, the symptoms resolved and the CT scan improved, and also the PCR is negative, so the patient is safe. So I don't think it is no need for another guarantee period. So I discharging from I'm a survivor from COVID-19. So, but my disease is mild. So after discharging from the hospital, I go back to work. So I have no transmission to others. So that is when we retrospect our experience. So I think the regulation is not needed. That is my own opinion. So about the asymptomatic patients. So in China, so we have instance rate. So it is lower than 3%. So so I think the first issue we should figure out what is a symptomatic carrier. So it in China, some colleagues reported that 30% are symptomatic. So I think that is wrong. So a symptomatic carrier should be the patient had no symptom from the onset to the end of the disease. So that is asymptomatic. So some patient, when they visit to the hospital or when they accept the test, so they are asymptomatic. But several days later, symptom appeared. That is not real asymptomatic carrier. So so if you rule out not patients, so the incidence is very low. So I think so that is important issue we should figure out. The infectivity of asymptomatic in China. So we have only a few studies dealing with this issue. So for COVID-19, so we have a reproduction number. So that is R0. So that means without any protection equipment, one patient can produce how many patients? So R0 for COVID-19 is 2 to 6 in China. So the mean value is 3. But a few studies reported that asymptomatic carrier, the R0 is only less than 1. Less than 1 is not a big problem. So the infectivity is very, very low. So that is why we should still pay more attention to symptomatic patients, not asymptomatic carrier. So, but if a symptomatic carrier can have some transmission, so then we can find symptomatic patients. So if the monitoring system is sensitive, so if you can find a symptomatic patient, that's okay. So you can trace the close contact, you may find a symptomatic carrier. So that is my opinion.
Yeah, I think it is important to for the audience to, when you look at the papers, to realize that viral shedding does not necessarily mean they're continuously infective. And I think as such, these questions are a little bit difficult to answer if you look at just individual patients. And I think if people are interested, they need to look at a more epidemiological model. And there are some papers that look at more stochastic model that actually shows that if you isolate them, this question asks about quarantine, if you isolate the patients for 14 days and you're looking really at reasonable risk, then the control should be reasonable. Then there are some very nice papers on that. But I think if you look at just individual patient and ask these two questions, it's difficult to answer. You're always going to get one or two exceptional patients that would remain infective after even 21 days of quarantine. In any case, I think we are pretty overrun, so I think we need to move on to the next section.
Yeah, and for those questions that didn't ultimately that we got to, or if people had questions that are listening, feel free to email and we can try to answer them at individual levels. So I believe, correct me if I'm wrong, but our next area that we're going into is treatment, and that would be Dr. Patel leading the charge. I've stopped thinking whether I'm right or not, so maybe I am or maybe I'm not.
Is that everybody got that up on the screen? So yeah, I mean, I got the task of the treatment, which is, I think we got about 30 questions. And so we'll try to get through 3 or 4 of them. Kyle, stop me whenever time's the limit. I just wanted to put a little plug into what Dr. Kreiner was saying earlier regarding, a good infrastructure for research is ultimately what we will need to define treatment algorithms. And here at Mayo Clinic, we've defined a group of a research advisory group, which works with the clinical trials group to define what studies we will pursue, how to perform those studies, and then a treatment review panel, which encompasses physicians from the infectious disease, critical care, pulmonary fields, who come together and make decisions on a case-by-case basis as to what therapies we are giving. And unfortunately, most of the therapies that we're providing, aside from our ARDS management of patients, tends to be anecdotal when it comes to the medical management of these patients. And that's the challenges that we face for the short term. So I'll start with some of these questions, and really we can move through these pretty quick just to get through as many as we can. So the first question that was received was, for severe COVID-19 patients, when should they be intubated? I think, the US experience based on the rest of the world was early intubation was preferred, and part of that preference was to avoid aerosol generating procedures in the form of non-invasive and CPAP. So have you guys still feel that is a mantra that we should continue?
I would be curious what our friends from China will say. I know we have been, by having our dedicated units from an aerosolization perspective, have been trying to do more high flow nasal cannula as well as helmet-based ventilation for borderline patients who are not necessarily needing ventilator support, but are needing higher levels of FiO2 than what is able to be easily achieved, obviously, through standard nasal cannula.
Are you guys seeing the different phenotypes of illness that have been described, kind of low elastance versus high elastance, or PEEP responsive versus non-PEEP responsive, and perhaps that may be our fork in the road as to what therapies to provide, or early intubation versus non-early intubation? Yeah,
the short answer is yes, but I would love to hear from our friends in China.
So in China, so we have some experience on non-invasive ventilation for treating COVID-19. So this mainly coming from SARS time. So as you know, so SARS, over 30% of SARS patients are very severe. So we most of the patients we give non-invasive ventilation. So and in our hospitals at that time, only 38% of fatality rate of SARS. So we use mainly use non-invasive ventilation. So we are very successful. So the experience that so when you use non-invasive ventilation, so you need to begin at lower pressure. So and then gradually increase the pressure. You need have time, let the patient have some time for get used to the high pressure ventilation. So so for non-invasive ventilation, I don't think it is simple. It is more complicated than intubated ventilation. So because it need the physician or the nurse to stay at the side, the bedside of the patient to observe if the patient can synchronize with the ventilation, and to guarantee if there is a large air leak. So it needs more labor work than intubated patients. So that is one of the key points. So we have some experience in that we use EPAP up to 11 centimeter water. So so that is very high, even compared to intubated patient. So, but that patient survived. So, I can say that if non-invasive ventilation is used suitable, so that can avoid a lot of intubation. So also in China, so we have a guideline. So we still avoid another bias. So we need, if non-invasive ventilation is not good, so in 2 to 2 hours, so intubation should be performed. So that is what we do in China.
Okay, I have some comments for this question. And we used non-invasive ventilation, just like what Professor Wang said. And at the same time, sometimes we use steroid, maybe 125 twice daily. And some patients recovered from this treatment protocol. So those steroid together with the non-invasive ventilation, we have 13 patients very critical, and after this kind of treatment, only 5 patients died from the disease. So it's very important to use the non-invasive ventilation with maybe very familiar with this treatment. Sometimes in USA, I know that there's a respiratory therapists that can help us to do this kind of things. Yeah. Okay.
So,
and Neil, I would say one quick thing real quick. We for those that are ICUs that are obviously non-COVID, we've always been very interested in avoiding intubation for all the obvious reasons, but we've very much, I guess, doubled down on our efforts there, and have also used this as an opportunity to push very hard with family discussions on limiting care when appropriately, obviously, to preserve ventilators for the COVID unit. So I'll leave it at that.
So I want to go to this question. Now, this was a very broad question. And so rather than kind of get into the details of, this is kind of the $1,000,000 question, how best to treat it, but I'm going to, the way I've broken down the treatment protocols medication-wise is kind of the antiviral, antimicrobial arm, and then the anti-inflammatory arm. So I was glad to hear a little bit about the steroid use, but what my thought was maybe just to mention some drugs and see if anybody has any strong opinions one way or the other regarding their use. And I'll start with probably the most commonly used, I suppose, which is hydroxychloroquine. As we all know, the evidence for this was based on some French studies and some additional studies suggesting increased clearance from the nasopharynx regarding a PCR in kind of the mild to moderate group, and not a whole lot evidence in the more severe intubated patients. So any anecdotal or other evidence that I'm missing regarding treatment with hydroxychloroquine in the severely compromised patients?
In fact, I don't think there is the best treatment protocol so far for those very severe patients.
What about,
so we make a decision for the patient according to the guideline of the Chinese government, and also based on the condition of the patients themselves. For example,
Yeah.
the age and the secondary bacterial infection, and also this kind of things for the patient. Yeah, make a decision. Yeah.
Any strong proponents for remdesivir as another antiviral currently under investigation?
So for antiviral agents right now, so we can tell that only chloroquine phosphate may be effective so far. So in China, we have several antiviral agents besides chloroquine phosphate. So Abidor, so it is another agent for anti-influenza. So maybe not used widely in United States and Europe, but it is available in China and also in Russia. So for in vitro study, so it can inhibit the virus. So very limited experience in Wuhan. Some Chinese colleagues told me that it is effective. But right now, we need more clinical trial for this drug.
Yeah.
So another drug, lopinavir, ritonavir, is also available in China. So indicated for HIV infection. I use lopinavir, ritonavir myself. So after only 2 doses of treatment, my fever faded completely. And in Korea, South Korea, they have some experience. So they can decrease the virus loading. So that may be useful. So for a recent published paper in New England Journal, so talking about the new clinical the clinical trial, the only clinical trial for COVID-19 using lopinavir, ritonavir, it is negative. So it cannot change the primary outcome. How to look at the result? So to my opinions, so antiviral agents, so we should use more earlier, not too late. So, but these clinical trials, so they use, they enrolled severe cases, not mild cases, or mild cases with high risk for developing severe cases. So I think the design of the trial has some problem. So I think if you design a new clinical trial in the United States, so China right now, we don't have such opportunity. So perhaps you need to enroll mild cases with high risk for high mortality or high risk for developing severe cases. So that may be may get a positive result.
Yeah.
The
We're going to get to some of the. Oh, go ahead.
Yeah, the golden question is always whether the treatment works or did the patient got better themselves, right? And early on in Hong Kong, we used Caletra with ribavirin and with interferon if they're early in the disease, but not after 7 days. And we were able to get a few of the very ill elderly patient out of ICU and then eventually discharged. But again, like I said, we don't know whether we simply waited out and then the disease got better. But that's the study that we did, and that's the unofficial protocol that we are now using in Hong Kong after the study recruitment has finished. And in Hong Kong, fortunately or unfortunately, our cases, we have almost just short of 1,000 cases now. Our mortality is 4. And I don't have the official number, but we have a total of 16 in ICU throughout the whole period. So it's just 16 patients. But that again, that might be, of course, we are testing everybody, so the denominator might be big, but I don't know. And of course, we did universal masking very early on, so I don't know. The numbers are very complex, but maybe the collateral with the rubber variant with the interferon, maybe that works for the severe cases.
Yeah. Okay, I think there's another.
Something about the chloroquine. And so far, there was a clinical trial finished in China. It was the PI is Professor Zhong, my mentor. This trial include 197 cases. The dose for the chloroquine is 1 gram per day. For 10 days, though the results show that the day from let me see so the shorter time to reach the undetectable viral RNA for the clinical for the treatment group compared to the control group. For the chloroquine group, is the time for the virus turn to negative was 3 days compared to the 9 days for the control group. So I think this trial showed that the treatment seems to effective. So I would like to add our result for the chloroquine.
Yeah. Thank you. So I think there's one more question about kind of some of the IL-6, IL-1 blockers, but just to move on and hit one or two more points here. Proning, I think there was a few questions on proning regarding proning patients that are not intubated, additional questions regarding concern of proning and worsening hypercapnia, which I don't believe was seen in the ProSiva trial. So I'm not sure that that's a true concern, but just wondering if you guys have seen anything like that. So anything with proning, any insight there?
Yes, I think the proning is very important for this kind of patient. In fact, we have some patients in a moderate situation. We also proning them, and I think there's these patients to progress in very critical condition. So especially in the patient with the lesions in the CT, just behind the lung and in the lower lobe, I suggest the proning. At least if the patient is conscious, we suggest at least 4 hours every day. And if the patient with the sedations, maybe 12 hours every day, I suggest,
Yeah.
Okay.
So I wanted to hit one or two other topics. I know there's a lot of discussion regarding microvascular thrombosis and dysregulation of pulmonary flow and the potential high incidences of DVT in certain groups, I think reported out of Italy. We are regularly monitoring patients with D-dimers and perhaps with ultrasounds, but what is your all's experience regarding the pathogenesis of microthromboembolism and its contribution to the hypoxemia and right ventricular dysfunction and downstream sequela?
In fact, I think in a very critical condition, the patient always have a very high D-dimer level, and we use the heparin, low molecular heparin for this kind of patient, especially in the patient with the intubation, with the sedation. We always use this kind of anticoagulation to prevent the thrombosis.
Yeah. In China, so we in our hospital, so we should evaluate the risk for vascular thrombosis. So if the patient belongs to a high risk of thrombosis, so then this patient will accept anticoagulation therapy. So if it is not, so we do not care about the D-dimer. So because it is not the evidence of thrombosis, but it is evidence of infectious disease. So that means the patient may be severe. So and also we should, if the patient need anticoagulation, we should evaluate the benefit and the risk. So if the patient have a high risk for bleeding, so we will have a preserved anticoagulation therapy. So,
have you guys seen on autopsy any findings to suggest kind of exaggerated thrombosis, more than would be expected from just a viral infection in the lungs?
So autopsy is too late. So for that kind of cases, anything can happen.
Yeah. Okay.
I have some words for this.
Go ahead.
As the pathologist said that there's maybe embolism, small embolism in the very small vascular vein in the lung. So maybe that's can explain why the D-dimer increased a lot. So that's why we sometimes use the anticoagulations. It's just like Professor Wang said that we should evaluate the risk of bleeding, for example, GI bleeding. Sometimes we should evaluate. Be careful.
Sure.
Yeah.
Okay.
First, no harm.
Yeah. Let's get to this question, because I wanted to touch on this. I know there has been a lot of press about this, but this kind of entity of a cytokine storm occurring, or at least treatment agents against IL-6, IL-1 to prevent kind of an exaggerated immune response, that as well as steroids. Are you guys seeing any, we're following in our institution kind of very generic inflammatory markers and following the time course of these patients. And I think it's very difficult without viral loads to know whether the inflammatory response is appropriate or inappropriate. So I personally am a little skeptical of using these agents without knowing whether the virus has partially cleared or clearing. I don't know. Have you guys had much experience with tocilizumab or anakinra or any of these agents against the interleukins?
In fact, there is some patients, yes, sudden rapidly progressing the respiration failure within, for example, 1 week or 10 days after the onset of the symptoms. But we have could not measure the cytokines in our hospital, so I cannot tell the level of the cytokines. And we should pay attention to this kind of patient with the high risk of the progression. For example, the age older than 60, and also some chronic disease such as hypertension, COPD, and chronic kidney diseases. So this kind of patients should be paid more attention to. Also, some patients with high, with the heavy smoking should be paid attention to. Yeah.
So I think the early intervention, early treatment of COVID-19 patients should be very important. So we should not wait for the patient to get very severe. So then we treat the patient. So I think that may explain why we have some very young patients passed away. To my own experience, so that we need to keep alert to the patient development. So COVID-19 is very interesting. So we can see it is most of the patient is very mild. So the fever up and down, and even some days no fever. So, but the 10 days of the clinical course is very important. So, after onset of the disease, at 10 days, so this kind of patient may have a very sudden deterioration. So, and the respiratory failure appeared very similar to United Kingdom Prime Minister. So, Boris. So for this kind of patient, some physician may neglect. So it is a mild case, no problem. But at 10 days, so the patient will get worse. So another things is that you need to have more early intervention. So like non-invasive ventilation. So there is some biomarkers can alert us that the patient will have a very severe rapid development. So first is high fever cannot fit it. So and second, high CRP level, LDH, high LDH level, and also rapid development of infiltration from chest X-ray. So,
I just want to make a comment to emphasize what Gongfa and Fengming and Shui said, that in our experience of 600 plus, that the early aggressive treatment of cytokine storm, coupled with non-invasive forms of ventilation, I think is key to avoid the need for invasive ventilation. In our experience, we only need intubation and positive pressure ventilation like we would normally use 14% of the time. And the remainder, close to 26% of the time, high flow nasal therapy or non-invasive ventilation can tide the patient over through the tenuous early phase of their disease. So I think that's a little bit of a message that this push to early intubation for infectious concerns, I think, is overplayed in the US. I do think you can use these non-invasive forms wisely, coupled with aggressive treatment for cytokine storm, and prevent a lot of these patients from needing intubation. And I think that contributes to the morbidity and mortality.
Absolutely.
Eric, maybe some stuff.
Neil, why don't we do one more question and then we'll move on to the final.
Okay.
I'm sorry, go ahead, Fengming.
Yeah, I noticed that some staffs just afraid that the aerosol to spread the virus to the staffs to be infected. So don't want to use the high flow and maybe non-invasive ventilation. But my suggestion is that with the proper personal protective equipment, I think the high flow and non-invasive ventilation is safe. For example, we always practice like this in Wuhan. So nobody infected with the high flow or non-invasive ventilation.
Totally agree with
you. Yeah. Okay, so last question here.
I have a question. Sorry, I have a question about you. We are very concerned of the aerosol. So I would like to know, are there any equipment to detect the aerosol in states?
We do not.
Okay.
No. What we've done at organization, Shui, is we've like coupled the patients on high flow. We've put them in a certain unit where all the staff is protected, like Feng said, and we use viral filters if we're giving nebulized treatments and whatever that are about 99.9% effective overall to decrease the airborne distribution of droplets. So I think there's things you can do from a protective standpoint for the staff that makes these less invasive therapies effective and not dangerous.
Yeah, that's true.
Yeah.
Okay, I guess the last question we'll go over, maybe perhaps the use of pulmonary vasodilators, prostacyclin or prostaglandins and nitric oxide and agents or in individuals where the lung compliance appears intact, but the profound hypoxemia may warrant additional more invasive therapy or non-invasive PAP therapy. Any experience?
We don't use such therapies in COVID-19 patients. We don't have such.
Yeah, I have. We don't have research, but I have a patient with hypertension of the pulmonary artery. So we use the prostaglandin for the patient. The patient, just one patient, so with just for the hypertension for the pulmonary vascular. So we don't know, but the patient survived from the COVID-19. Yeah, that's what I can say. Just one case. So okay.
Okay. All right. I'll go ahead and swap over, and you guys can bring up the discharge.
All right, Jerry, I'll pull up the slides and okay, what do we got here? Discharge and click. Okay. So this is a very relevant question because obviously we're all doing all of this to make sure that we have patients that are discharged, typically with high levels of critical illness and prolonged hospital stays. So could our friends from China who've had experience, or also Jerry, you guys and you have been in the heart of it as well. What have been your post-hospitalization needs that people can anticipate beyond the standard needs of a critical care patient, post time in the ICU, rehab, et cetera, et cetera?
Yeah, I'd like to hear from our Chinese colleagues first about how do they assess and when do they assess patients being discharged.
Yeah, when the patient we have treated after discharge, there were 2 or 3 cases. The RNA virus RNA was positive again. So in about 30 cases so far, we found that 2 or 3 cases RNA positive again. So I think this should be pay attention. And another point that so far we have followed up about 1,000 patients checked with the lung function. About 40% of the cases have a diffusion capacity decline. So this is the 2 points I've shared our data.
When do you think it's safe to do pulmonary function testing in patients? Do you swab them a couple times and make sure they're negative first, or separate equipment?
We after discharge reach the index of discharge, and then we isolating 2 more weeks, and after 2 more weeks we detect the RNA again. The RNA, if it was negative, and then we can check the lung function.
Okay.
At what did you still have persistent radiographic abnormalities when you found those diffusion defects?
Pardon? I cannot catch the
Do you still have radiographic abnormalities at the time of those diffusion defects? And do you think they're long-standing, or do you think they would still be fleeting over time?
I can answer your question. So most of the patients with COVID-19 when discharging, they have still have abnormalities for CT scan. So most of them are infiltration. That is the inflammation is not resolved completely. Only about 6% of the patient have pulmonary fibrosis. So honeycomb like lesion. So and I don't think it is a big problem for most of the patients because with the faded of inflammation, maybe from our SARS experience, most of the patients will have clear bilateral lung in about 2 years. So lung function dysfunction, pulmonary dysfunction is not a big problem for most of the patients. Only one in the hospital. So
yeah, I see. Yeah. Okay. Go on.
Please.
Go on. Go on. Yeah, I agree with Dr. Wang, but I think it should be for the patient discharge. It should be follow up with the lung function or maybe a CT scan, maybe 3 or 6 months later. Okay.
How about blood markers for like D-dimers and ferritin and CRP? Do you routinely measure biomarkers of inflammation post-discharge or not?
We don't have the monitor the biomarker for this kind of patient. If the patient have a high abnormal, maybe we should monitor it. In fact, that's the Professor Lee said that there's a positive again. So that's why there's another 2 weeks quarantine in China. So I think that it's maybe reasonable for some patients. Another thing is that the patients maybe sometimes discriminated by other people in the society. Maybe sometimes in the family, sometimes. Yeah. So
well, and that leads to this question because Jerry, I don't know if you've had this experience yet, but you can anticipate all the needs for discharge. Neil, the same thing, but the center you'd like to transfer the patient to for any form of rehabilitation is either not accepting COVID patients or demanding another test, even though we have limited testing resources to prove. Have any of you run into this, or are you aware of plans to try to change this?
It's dialysis centers too. If you're not swab negative, a dialysis center won't take a dialysis center patient back.
And that's the challenges with the PCR, which could still detect virus without viable virus still present. So, I don't know if repeat PCR swab being negative is even that reassuring to them. It may be, but in reality, it may not make a difference.
And can I ask, in any centers that are doing neutralizing antibody as a marker of sort of a loss of infectivity, particularly, I know Professor Zhong is really a believer in IgG.
So in China, antibody at the first time, at early stage, so now antibody test was available, but right now, so we have antibody test, neutralizing antibody can be tested. So, but we don't test it routinely, except for a clinical study. So, but if some survivor want to donate their plasma, so we will test the neutralizing antibody. If it is over 160 titers, so we will the survivor can donate their plasma.
Yeah, because the reason I ask is I think one of the direction that we are definitely going in terms of treatment is, of course, with convalescent plasma. So one of the possibility is a lot of countries might be asking for a lot of these tests very, very soon. And if we do believe that neutralizing antibody is a marker for a loss in infectivity, they're a marker for them being donor for treatment and loss of infectivity, then maybe this could be a way of confirming to others that they are really non-infective, because I believe, like I said early on, viral shedding with increasing sensitivity of PCR, maybe you can still get 1 or 2 dead viruses in the nasal pharynx if you do it deep enough, etc. It does not mean that it is shedding. It does not mean that it is the patient is still infective in a sense. I don't know whether some views.
I agree. Thank you.
How about some practical things? If you've recovered, how long after your initial presentation should that patient continue to be wearing a mask around others? These are some of these bare bones normal questions, right?
Yeah, forever and ever from Hong Kong side.
In China, the government asked everybody to wear a mask when they met others. So I don't know. I don't think it is needed. So, but for I must when I discharging from the hospital, so I stay at home. So I do not wear mask. So my my family do not have been affected. So right now in China, so there is no non-report about the patient discharging from a hospital infected others. So that is very important. So if the patient recovered, it seems that there is no effectivity.
I thought we'd have one final question because we're going just a little bit over. Do we have any, this was a question that I actually brought up on our last panel, and I know others have asked it on our online forums. Do we have any kind of recovery indicators, or maybe put it a different way, thinking of some of our severe patients who are getting near maximal ventilation, and we're starting to consider things like ECMO, or considering the various, Neil had talked about in the prostaglandins and inhaled prostacyclins and et cetera, et cetera. With those in limited supply, we like to be judicious in who we apply them to. Do we have experience from China in the severe category, as Jerry outlined, that sort of group 4, any kind of markers to predict who's got a chance for meaningful recovery, and therefore we should be applying these limited resources, and others where they're less likely to work? I'm pessimistically, unfortunately, thinking the answer is no, but I'll throw it out there.
It's very difficult. Yeah. We have almost 70 patients in our ICU during the almost 12 months, and we have 20 patients died from the COVID-19. So sorry for them. And especially, I think the age should be concerned, because most of the patients died, very old patients, for example, 80 years old. Even if you use the intubation, ventilation, and maybe ECMO, they still progressed and died from the treatment. So the age is the first thing we should consider. The second thing is that some chronic diseases such as diabetes, hypertension, and also chronic kidney disease. And we have several patients with this kind of condition died from the disease. So also some patients with non-disease, for example, COPD and heavy smoking in the past. And so we should pay attention to this kind of patient. When you choose because of the shortage of the facility, so consider the patient with young age and without the chronic diseases, and then that's our experience. Yeah.
So, to my comprehension, so you mean that when the patient should move out of the isolation ward, right?
Sorry, say that again.
So, do you mean that the patient recovery means that the patient can move out of the quarantine, right?
Well, I think that's definitely one part of this question.
Oh, yes.
For sure. So please.
Yeah. So in China, so we will treat the patient. Most of the patient will be treated until the patient recovered. So there is no ventilation, there is no need for ECMO, and the patient has no fever, and the respiratory failure is stable. So, but if the patient, the PCR is negative, transferred to negative in some cities, so they will move out of the designated ward. So that maybe that kind of patient can be treated as other patients. So, but only a few cities. So, but most of other cities, as they don't have so many patients, so they will treat the patient until the patient recovered. So,
okay, Jerry, have you guys of the hundreds of patients at Temple so far, have you had a scenario where you've needed ECMO or had a group of patients and then had the debate of do we want to use it or not? What are the factors as were listed out earlier?
We just used it in our second patient out of 624 today. They're both patients that were younger, in their mid-40s, that basically we couldn't ventilate. One had to have a cricothyroidotomy, and we couldn't do a trach until we could stabilize the patient. So there was other extenuating circumstances. But I think ECMO is, it's less than 0.5% of the total patients that were used that we consider.
Okay.
So can I have a question to United States colleagues? So as you have more experience on ECMO, so in China, so some patients accept ECMO. So out of Wuhan, so about 1/3 of patients survived from ECMO. So, but in Wuhan, the rate is much lower. So, so in your experience, when will you give the patient the ECMO? So, what's the indication? That is my my question. Thank you.
It's pretty much, we use it as a salvage maneuver for people that are on positive pressure ventilation and can't be oxygenated despite proning, inhaled vasodilators, and basically high levels of PEEP and ventilator support with protective lung strategy. So both of these patients were on PEEP of 22, mean airway pressure was pretty high, it was about 30 overall, and patients couldn't have a saturation above 90% despite 100%. So really critically ill, severely limited patients, but it was the rare patient so far in our experience.
Yeah.
In China, so we have some lessons from the early treatment. So almost all the ECMO patient passed away. So in the recent, in the latest version of Chinese guideline, we moved ECMO forward. So if ventilation is not effective, the patient still have hypoxia, and if you need high plateau pressure, so over 35% centimeter of water, so then it is recommended to use alcohol.
Kerry, I have a question about the group immunity. How about your opinion about the group immunity?
Oh, okay. Yeah.
Do you think it makes sense?
Which immunity?
Group.
Herd immunity, right? I think,
Group immunity.
Yeah. Thoughts amongst our panelists?
Well, no scientific basis, but I think eventually it would be vaccine-based. It's not going to be based on infection, I think.
Here's hoping not. So most of us talk about this conception, and especially in Europe countries.
So to my opinion, so we have positive immunity and passive immunity. So if you let most of people infected by the virus, so that is passive immunity. So if the disease is something like influenza, so most of patients are mild and the mortality rate is low, so population immunity is not problem. So, but COVID-19 is not influenza. The mortality rate is much higher than influenza. So although we have about 80% of patients are mild, so that is a mild and moderate case. So the mortality rate is very low, but we still have about 20% of patients are severe or critically ill patients. So the mortality rate is about 10 to 20%. So I don't think it is it can be the same as influenza. So passive immunity is not good. Should be avoided. So if you don't want,
I agree.
We have so many people passed away. So that is my own opinion.
And I know it's a bit overrun, but I want to go back to a very quick comment about mask. We are strong proponent of mask. Even for those that are discharged, I agree that they are not infective for others, but before, again, looking at the whole community, in Hong Kong, from the experience from Hong Kong, is that with masks, even if, especially in the future, in the near future, I think the supply would be a lot more stable. Mask not only protects others, but it protects yourself, and we can never be sure whether what would happen and whether we can completely rule out reinfection. And once this universal masking started in Hong Kong, we actually forcefully stopped the peak influenza season 2 months early. And so we were able to reduce all the COPD and asthma exacerbation without really causing a lot of problems. And we spared a lot of beds for the, we spared a lot of staff for the isolation facilities. So I'm not saying wear the mask like really forever, but at least ride it until the epidemiology peak has passed. And I think that makes sense. And I honestly think that early on, a lot of comments about, okay, if you wear a mask, you touch your face more, that should be dealt with by education and not by avoiding the usage of masks. That's just doesn't make a lot of sense. Teach them to wash your hands before you touch a mask. That's my point.
So I agree. So mask is effective for the prevention of the spread of the virus. So in China, we either ask the patient to wear a mask, and also we ask others when they have go to people gathering areas, so to wear a mask. So although for individual protection, we need three rules. First is to keep social distance. The second is hand hygiene. The third is mask. So it is very effective with the COVID-19 controlled. So we all also observed in China. So influenza is stopped. So very interesting. So although we at the time of influenza, so not is effective. So I learned some saying but the mask is not used. So I don't agree. So mask is useful. So the problem is that if everybody wear mask, so the production capacity can fulfill the whole world. So that is the problem. So we experienced some shortage of masks. So in China, so that is a problem. So I think in the future, maybe China can save some masks, can export to other countries. So, but we still have some problem with wearing mask, like in the area of outdoor, everybody wear a mask, so nobody near him or her. So that is we need to change. So at that side, you don't need a mask, so you can save the mask. So when you are entering to the shopping mall or to the some indoor place. So that is my suggestion. Thank you.
Yeah, good.
Well, Jerry, so we've been talking for a while, and we're running a little over, actually a lot over. So I want to be respectful, and our colleagues in China are trying to start their day, and Jerry and I are trying to wind ours down. Neil too. So any final thoughts from our panelists? Things you've been wanting to say that you didn't get a chance to say yet?
No, I totally enjoyed talking to people from China and Southeast Asia because, you know, they've lived through this twice, through SARS and through COVID. And their experiences, I think we have a lot to learn of, both how they manage the patients and how they, all aspects of it, from prevention to treatment, the population kind of health, and then the discharge follow-up. So I think that learning from them has been key for us to try to like prepare ourselves. And I really appreciate their time and their efforts.
Agree.
Yeah, thank you very much.
All right, well then I will wrap that up. If there's no kind of other final thoughts, I will say xie to our friends in China, and to everybody else who's logged in. Thank you for being a part of this. And thank you, of course, to our friends at Broncus who put this up and took the time to get everything together and organize it. So my compliments to them, and also the support through the Society for Advanced Bronchoscopy. So thank you very much, everybody. Have a good evening or morning.
Thank you.
Thank you.
Bye-bye.
Bye.